Sure. Thank you, Larry. I'm Bruce Hochstadt. I'm a physician by training, and I have worked both in the employer on-site business with a operating company, as well as spent over a decade at major consulting firms advising employers on health center and health services strategies.
Thank you. Just so you know, Paul Marcino from Gilbert Partners could not get out of LaGuardia, so he is not joining us today. Brita, would you introduce yourself, please?
I'm Britta Ryerson. I'm a physician as well, Senior Medical Director at Optum. I have been in the employer space for about 15 years now. Real passionate about on-site health and worksite health, and glad to be here.
Brita's been very kind enough to sit in and join us. Laura?
Hi, I'm Lori Barron. I work for Stock Health. I spent half of my career in physician practice management and moved over to the employee benefits space about 13 years ago. So it's been really a great opportunity, and happy to be here today.
Thank you. Karen?
Hi, good morning, everybody. My name is Karen Anderson. I'm the Vice President of Human Resources and Corporate Compliance at Shell Point Retirement Community down in Fort Myers, Florida. We have had a worksite on-site clinic since 2010, and recently, about 4 years ago or so, layered on the telehealth component as well.
Thank you all. All right, so again, I'll ask a series of questions. If you have questions, text me at 847-606-5527, or just write them on a note card, hold them up, and our staff will pick them up. So I'll start out with you, Bruce. So why should a worksite center offer virtual services?
Most employers do this to enhance access to high-quality care that's affordable. And to Larry's question, if virtual allows a heightened level of access and convenience for employees and eligible dependents, I think that says it all. And what we're seeing is certainly an acceleration of employers saying, although I may be concentrated in a few locations, whether it's large plants, distribution centers, call centers, or headquarters, I may have countless employees scattered at smaller remote locations. Virtual care allows them to have some level of access as well. But nonetheless, there could be employees at a corporate headquarters that, David Kite and I once worked with an unnamed software company in Redmond, Washington that had upwards of 50 buildings over a sprawling corporate campus. And in this part of the Pacific Northwest, it rains a lot, and these programmers, developers, and engineers could be in the middle of a major project deliverable and didn't want to take 20 minutes to walk one way from building 47 to the health center in building 11. If a virtual consult made sense and was clinically practical, why not, even though there was a bricks and mortar center? So I hope I added some color to your important question, Larry.
Great, thank you. Brita, your perspective?
I'd probably echo that, Bruce. I think the other aspect of virtual integration is with this dispersed workforce, of course, there's always that opportunity of right care, right time, right place. And there's so much we can do virtually to accommodate all of our patients, whether they're dispersed or not. So I think it's changed the way we've done healthcare, the way we've managed our patients more efficiently.
Great, thank you. Laura, give a little background on First Stop Health.
Well, we're a virtual provider. We provide virtual urgent care, that telemedicine that we've all been familiar with for many, many years. We also provide virtual mental health and virtual primary care as well.
So why do companies come to you for virtual care?
Well, exactly as the others that spoke about, we're really looking for the opportunity to meet the need and meet those 60% of members in your workforce that don't have a primary care physician or don't have easy access to virtual urgent care. We're able to divert inappropriate ER urgent care, even office visits, and manage the patient in a very delightful way.
So Karen, in your perspective as an employer, why offer virtual services?
Well, let me start with the on-site first. I mean, truthfully, the reason we started an on-site clinic back in 2010 is that's the year that we went self-funded. And we were looking for some claims avoidance, quite honestly. And that worked out well, the on-site clinic, for the same reasons that the other panelists have said. It's great to have one, but access, when our clinic was only open 3 days a week due to the size of our employee population, there were the days that it wasn't open, the evenings, the night times, the weekends. And so initially we offered it to everybody on the group health plan. And then round about COVID time, we had part-time employees coming to us saying, hey, I think I have COVID, I need treatment, I need to get tested, I don't have insurance. And so we opened up the virtual services to all employees and their household members. And so that's an added benefit for the employees, and we wanted to make sure they had access to that care. So.
Great. And so what kinds of virtual services do you offer?
So we offer medical, and then we added mental health, again, right around COVID, because obviously people were struggling a lot emotionally, and the availability of those services locally, I think with many areas it's tough just to call a psychologist and say, hey, I'd like to make an appointment. And so acute care is the biggest issue. My son has an earache on Sunday morning at 2 a.m. But we have seen a dramatic increase in the use of the mental health component.
So Bruce, what kinds of services do you find employers are most interested in virtual care?
Well, I think what historically was known as acute episodic care has proven to be most amenable, Larry, and I think that's where employers see initial value. I could read from a WTW study or analysis that I was part of over 5 years ago, pre-pandemic, and the conditions were the common ones that you'd expect, whether it was acute runny nose, acute rhinitis, pharyngitis, upper respiratory infections, some headache, as well as hypertension, hyperlipidemia. So those conditions have a very high correlation with being comfortably managed in a virtual setting. But as we had heard from Lori, behavioral health has become very, very amenable to being rendered virtually. And for a lot of counselors as well as psychiatrists, that has become the dominant mode of their practice. We are seeing emerging techniques for virtual physical therapy or managing musculoskeletal conditions, and I think it's going to expand. Employers are trying to capitalize upon it with the theme of, does this provide enhanced access affordably to high quality care for as wide a swath of my population?
Great, thank you. So Rita, what virtual services do you think are most important, and what services perhaps do not fit into a virtual setting?
When I think of primary care, we all know you can't do primary care 100% virtual. There needs to be some sort of a connected care component. But to speak to the 100% virtual side, there's a lot of what we can do 100% virtually. And when I think of that, I think back to my practice. And what were those visits where I never laid a hand on the patient? Granted, we got vitals perhaps, but there are other ways we can get that. We have peripherals. People can buy anything on the Amazon nowadays. So I think there's an aspect of we can do anything virtually because we can use our best clinical medical decision making and triage and navigate the patient to where they need to go. And we can also really, I get back to that, meet the patient where they are, because we also know in healthcare, the more we engage with the patient, the more engaged they're going to be in their own health and their own health improvements. So whether that's virtually and then I see you in 3 months in person, and then maybe 6 months later I see you virtually again, that more connectedness is going to help those long-term outcomes.
Thank you. Lori, how does virtual care help fill gaps?
Well, virtual care, we see it as being a great equity for members that are having barriers to access. We all know there's a huge physician shortage across the country. So being able to access a virtual appointment or on-demand appointment in a matter of minutes, a matter of days, is really key in helping people get engaged with their health, find immediate answers, and then, of course, when referrals are needed, we can do that as well.
Thank you. And Karen, so how do your employees view virtual care? Were they uncertain about it? Were they comfortable with it? How did you get them to accept it?
I would say they were 100% comfortable with it when it was introduced because it was a convenience for them. And I would say that the biggest factor is when they get on that phone, right? And how quickly there is a response and how quickly their issue is resolved.
How quickly can you get access?
They can get a phone call in as quickly as 2 minutes. Anywhere from 2 to 6 minutes, they get a phone call back on the phone with the physician or on video chat. So that makes a huge difference. I said to our provider, we haven't had one complaint in the years that we've had the program. Which is how we know if there's a problem, right? Because employees are complaining about it. So, no, we had a very quick adoption of it. The adoption of the behavioral health has been a little bit slower, but it is growing exponentially.
Thank you. Lori, how does virtual care compare to in-person care?
Well, there are a number of studies that are showing that virtual care can be as or more effective depending on the condition of the patient. Virtual care, in our mind, is never here to offset direct face-to-face care. But it can augment, and for some patients that are very challenged with getting to a doctor for whatever reason, it can be a great starting point and sometimes a solution for that patient altogether.
How about in your experience, Rita? How does this work? How do they connect?
I think very well. So let's think of an on-site clinic, and the patient is unable to come in. You're the primary care provider. You can see them virtually for anything and help them with that. It's definitely an augment. I also like to think of it sometimes as a wrap. So it's that wraparound care. I'm in Arizona and I'm not next to the office. Can you help me with this? So it's just that added level of support and care that you can provide your employees. And to tell you the truth, I think more and more people are coming to expect it. Just like they expect to go on their phone and have a delivery by Amazon by 2 p.m. that same day. I mean, they expect that service, that immediate gratification.
Thank you. Bruce, when employers before COVID used teledoc, doctors on demand, they were getting 10, maybe 15% utilization. Since COVID, utilization clearly has gone out. Why do you think it's gone up so much and will continue at this high spiral?
Sure. I think, Larry, you're being generous when you said 10-15% utilization. My consulting days were seeing it as low to mid single digits, but nonetheless, we use the trite expression, COVID changed everything. Necessity is the mother of invention, and the opportunity to go to a clinic, a physician's office in person for several months once this pandemic took hold was not an option. A lot of practices either shut down or were scrambling, and eventually figured out that a good amount of primary care, as well as specialty care, could be managed virtually. So, I think that there was a tremendous acceleration, both in patient adoption. Patients got more comfortable. It is behavior change. You know, I'm used to, as much as it's not necessarily efficient, I'm used to leaving work, the office, the plant, going to the parking lot, driving across town or several miles, parking at the office building and waiting 45 minutes in the waiting room for an appointment. Patients, as much as they didn't like it, and it certainly wasn't consumer friendly, they were used to it. It was the status quo. Once they realized that's no longer an option, they saw that a telemediated visit was very, very efficient, and for a lot of conditions could manage it. Similarly, providers, and you know, as a physician, along with Britta and many in the audience, you know, they're not always the earliest or best adopters, but that too became the way practices were conducted. And we've seen an adoption curve that's been accelerated, or the slope has been less steep, both on the provider or the supply side as well as the consumer and demand side. And employers certainly have endorsed that. I mean, a lot of the motivation besides enhanced access to quality, convenient, and affordable care is efficiency. And for many employers, even in white-collar environments, might I be able to reduce lost time and absence and boost, whether it's production or worker efficiency?
So Karen, how have your people adapted now that the pandemic's over with virtual care? Are they more using the in-person? Has the level stayed the same? What do you see?
At least the telehealth has definitely gone up, and it's for all the reasons that we discussed here. The convenience factor is huge. And we do see use in off hours and off days, but we always also see use on the days that the clinic is open. You know, we are located toward the beaches, and so we have a lot of frontline employees who live half hour, 40 minutes away. And so if they're off on a Wednesday when the clinic is open, they're not going to drive into the clinic. They're going to use the telehealth. So we have, again, seen an increase in the telehealth. And then the use of our on-site clinic is back to pre-pandemic levels.
Lori, can any service provider do virtual services, or do we have to train them or get used to talking in front of a monitor? How does it work?
Well, the physicians could probably speak better to that than I can, but I'll say that our physicians, the key is to make it, the technology, as easy as possible, to not complicate their lives. Our physicians primarily are virtual. Some of them do still have practices or work in the ER, but they've adopted the technology and the virtual office, if you will, and it's actually helped their life balance. So they have early appointments, late appointments. Of course, our on-demand is 24/7, but I think if you ask a physician that has moved or maybe is doing part virtual and part on-site, you'll find that it really gives them some freedom in their personal lives to manage in a different way than they did before.
Read the same question. How are providers adapted, and can any provider do this?
Well, there's always going to be a provider who doesn't want to do it or cannot do it, but truly speaking, there's somewhat of an art to it in terms of engaging your patient through a screen or through a phone. But once you get used to that, it doesn't seem any different. That patient is right in front of you. You can see body language and facial expressions. However, there are some things that the provider needs to learn about how you need to carry yourself and speak to the patient. But I'll tell you, we've also had to educate our patients on what's appropriate. The ninth hole at the golf course is not an appropriate place for a virtual visit. So you wouldn't believe how many times that has happened to my group. So it goes both ways. But the digital technology is there. It's just how do we stay abreast of it as physicians and as medical groups.
virtual care is freestanding, it's either virtual care or in person, or does virtual care augment and assist by in person?
Yeah, so Larry, it's an important question, and I think it will depend on the circumstance, but all of those, whether it's augmenting a relationship where occasionally you will see that provider in person, and for certain situations or circumstances, it'll be virtual, depending on, the circumstance and geography plays a role. Virtual will, it'll be a virtual first, if not a standalone model, but, as you've heard from others, not every condition is going to be amenable. There is going to be a subset of primary care encounters where you need to touch and feel, poke and prod the patient, and as best we know just yet, there isn't a peripheral for that. But think of it and, to the point that Britta was making, it's an adoption curve. Certainly younger physicians, including medical students going through training, they're shadowing senior physicians or attending staff, and that's how they're conducting their consults. So they're going to learn it on the job. But virtual will, I think, be incorporated in any medical practice going forward if you want to keep your patients. Patients are going to insist, this is a far better way for me to receive care when it's clinically appropriate. And if you're not going to be there for me in that modality, I'm going to find another practice, another physician or provider. So it will be supplementing most folks who practice in the community. In the employer setting, and what attracted me to this niche when I was in consulting, it really is a patient-centric model, as opposed to when we trained, it was provider-centric. We were atop the heat. Patients have to sit in the waiting room or the second waiting room, the exam room, so be it. Employers don't tolerate that. In fact, there are performance guarantees around keeping wait times to a minimum. So it's patient-centric, and if patients are insisting, this is far more practical for me, that's how it's going to happen. We had worked in consulting with mining companies in very remote locations, whether it's New Mexico, northern Utah, northern Nevada. It could be 20 to 40 miles to see a primary care doc, and twice that for a specialist. Those visits are going to happen virtually first. And if it makes sense, if you're able to manage the patient and their symptoms, conditions, that's going to be the preferred mode of delivery for sure.
Rita, should the same providers who see people in the center be the ones who handle it virtual, or can you have a separate virtual provider and in person?
I think it's not one or the other. I think it could be both. I think they're both effective, as long as in the setting where you have the virtual provider and the brick and mortar provider, as long as there's that interface between the two. One of the biggest challenges that we can face is not getting the information. And granted, technology is wonderful, integrated medical records, care everywhere, but that's not always the case. And some of the telemedicine vendors may or may not have those interfaces into your EMR. So I think optimally, it would all be connected. But to give the best care, we need to be informed. So as a primary care physician, I would love to see my patients virtually and in person. That's perfect. But I would also partner with 100% virtual provider to get the patient that care.
So Lori, pick up on that if you would then. Does your services is all virtual, I understand. So do you integrate it with Karen's in-person staff or other, how does that integration work?
With our virtual urgent care and our mental health with Karen's team, we are not integrated with member level encounter data. We do have the ability to do that. All of the patients that are seen by our service receive both a recording and a written outline of the visits. So that can also be easily and quickly shared with the on-site clinic provider if and when it's necessary. So it really is client client by client, that certainly your virtual care provider should have the ability to integrate at that member level encounter data, because it can inform a lot of other pieces, and especially when we're talking about virtual primary care.
So Karen, how do you avoid the virtual services being a fragmentation of your center of healthcare? Do you find a way to bring that information together for your providers?
Part of it is educating the employee, right? It's no different than when they go to their primary care. We don't suggest they use the on-site clinic as their replacement primary care. So it's no different when they go to their primary care or they have a visit with the telehealth, that they should be following up with the on-site clinic. If follow-up is needed, or on their next visit, letting them know, hey, I had an antibiotic last week for whatever. Additionally, our on-site clinic and First Stop Health have been very amenable to making sure that a referral can be made either way, right? So if I call the on-site clinic after hours, I'm going to be directed to First Stop Health as an employee to call telehealth. If there is follow-up that's necessary through the telehealth, they'll say, hey, you have the on-site clinic, here are their hours, here's the phone number. And so we've worked to kind of integrate that way. As Lori mentioned, we haven't integrated data yet, but we've at least made that connection for employees, that all of those components exist and they should be communicating with each about what's going on.
Bruce, could you comment on the integration and how best to integrate virtual and primary care or virtual in-person care?
So, ideally, and the comment was made, it shouldn't be one versus the other. Ideally, you want the same provider or the same group of providers or practice rendering care. So there's a cohesive team and they're in touch with each other. Absolutely, Larry, when possible, and it should be as often as practical, it should be on a common EMR. So someone who is consulting with a patient virtually will have records of whatever prior encounters were, whether in person or virtual. You want to have referral mechanisms where when people do need care in the community, whether it's from specialists or procedures at facilities or ancillaries, that there's a level of familiarity and coordination. So if and when possible, reduce the fragmentation. And you want to have regular huddles and touch bases. In other words, people who might be, whether part of the same team or not, having a level of coordination and communication about a common patient that they may be seeing, regardless of the modality, virtual or in person. So integration is key, and there's a lot that can facilitate that, including, as I mentioned, a common EMR where they are familiar with the patient's background, medical history, and prior encounters or admissions.
So Rita, a lot of employers again started out with a third-party vendor like Teladoc or Doctors on Demand, and they weren't really connected with the center. Do you recommend employers now not use these separate third-party niche vendors, or do they integrate them, or do you use someone like First Stop Health or Optum that has a core set and works together? What should an employer do, or what are the issues beyond that question?
I think it depends on how dispersed the employer is with their population they're trying to serve. So, and then if the telehealth vendor is 50 state or is it not, that's really the decision maker. A full 50+1 state telehealth solution, those are the Teladoc, the Doctor on Demand, some of these other bigger organizations where it may not be interfaced or it may not be connected. You could still have that partnership and that agreement. However, if you are, as an employer, in a region, for instance, and you have your on-site providers, if the population is dispersed, then you run into a lot of regulation hurdles. Now with state licensure, your providers may have to be licensed in multiple states. There's a cost factor there. There's a time commitment. So though you step into Stephanie's world a little bit with the regulations and the compliance, so you need to be ready for that.
So Laura, when you have a national employer, and do you have to have all your team members licensed in all those states, or do you have regional teams for those states? How do you approach that and make sure it's legal?
Yeah, well, all of our physicians have multiple state license. We anticipated a setup for that, so that's just a core part of our offering. So we can provide services in all 50 states. We have those provider licenses in place.
Are there certain states that are restricted, that you have to have a physician in that state licensed?
I don't work with the credentialing piece with my organization. Whatever requirements are there, we're able to meet and follow those. And I apologize, I can't call out if there's any particular states.
Yeah, please.
Yep, there are 6 states that are physician-only states for telemedicine. South Carolina, I look at my colleagues here because this has been our world, but...
When you say physician-only medicine, what does that mean?
Well, there are a lot of regulations in delivering telemedicine in that state for advanced practice clinicians. So because of all of those regulations and requirements for a collaborator to be within 20 miles, things like that, we have deemed that an MD-only state just because there are less of those regulations. It makes it easier. But it can be challenging than if you have a 50-state model, having enough physicians that can serve the demand in those states at varying times. So it definitely is a challenge.
So, Laura, Karen, do you have prescribing? Do your virtual providers, can they prescribe it? Are they physicians or the nurses?
They're physicians and they can prescribe.
Bruce, can anyone prescribe in other states, or does it always have to be the physician? Virtual.
I need to defer to Britta on that. I suspect state pharmacy regulations in a few states back in the day were very finicky, particularly around on-site dispensing, and I have to imagine, but I'll defer to someone more expert, that there are also going to be some restrictions on virtual prescribing, depending on the states and then licensure.
There are definite rules. Controlled substances, for one. You can prescribe a controlled substance as long as you've had a face-to-face, in-person encounter with that patient in the 6 months prior. So that model works really well for a brick-and-mortar provider who's also doing telemedicine. But for a 100% virtual platform, that does not go over. But no. Right. But nurse practitioners, physician assistants, there are some variations between the states with different regulations, but they are very, very capable and able to deliver virtual care as long as they're licensed in that state.
Thank you. Bruce, how do we ensure that there's appropriate prescribing and referrals and prescriptions by the virtual provider?
Yeah, well, if I focus on the word appropriate, I think one thing that really has to be established, Larry, is an understanding of the patient, that it's not an encounter that you see advertised on late night TV. If you need certain lifestyle medications, dial 1-800, this, that, or the other, but you'd like to know that this is a legitimate provider-patient relationship, that there's an understanding what the condition is. And that can happen virtually. I think it's always enhanced when you know the patient, whether or not you've had a chance for an in-person encounter, and then have decided there's a level of trust and confidence where we can continue to render care virtually, but appropriate medications, and then knowing what is the right mode for distribution, whether you're going to prescribe electronically a script that can be picked up at a nearby retail pharmacy, whether there's going to be home delivery, mail order, and the like. But I think it dovetails in the theme of convenience. So, and a lot of, as we know, a lot of primary care conditions, whether it's acute episodic or more chronic, are going to be managed therapeutically by prescription medication. So knowing if this is not a patient in your community, where and how do they receive that prescription?
So Lori, how do you judge the quality of your providers and their delivery of virtual care? Is there certain requirements or reviews that we do of them?
Yes, all of our providers are clinicians, MDs or DOs. We have a number of quality metrics. They're practicing, of course, they have a clear medical license, no pending suits. They've practiced for at least 5 years. And we have very rigorous quality review, recordings of those providers, reviews with the providers and through our medical director team. So any interface with a patient is done by a physician. We do have nurses, nurse practitioners on the back end that are helping with follow-up around the patient's care.
Or is board eligibility?
Oh yes, absolutely. Board eligibility, certification, all of those basic metrics have to be met. And then there's some additional metrics on top of that, as well as practicing for at least 5 years.
Okay. Karen, do you find that the offering of virtual services causes induced demand? Are people like, how do you make sure they're not overusing the virtual care for things they wouldn't typically use?
Good question. We receive reporting on a regular basis from the provider, and I don't know how I would define overuse, because the majority of the contacts with the provider seem to be of an acute nature. We know what they're prescribing, right? We get a report on the top prescriptions and top diagnoses and that sort of thing. And so I don't see that employees are really abusing it. What we do know is that we are keeping people from ending up in the urgent care and the ER, which is great from so many perspectives, right? But we don't see an abuse of it. I think employees use it for what it's there for, which is a convenient option when they have some kind of immediate need that they want to have checked out.
Right. Bruce, you have a comment on induced demand and the impact?
Sure, Larry. It's something you always think about when you enhance access and convenience, and certainly, virtual care would fall into that category. So might folks seek an encounter because they can, and they can do it, within minutes or a few hours, versus, I need to get an appointment, and it might be 2 or 3 days, and sure enough, whatever I have acutely is going to be better, and I won't have that unit of care or utilization. But in the scheme of things, I think it's a nominal factor, though it's one worth paying attention to. These are more efficient encounters from a time standpoint. So if an employer is worried about a productivity loss or some lost time and absence, that might be minimal. The costs are going to be more nominal as well. So I think in the scheme of things, yes, there will be a little induced demand, but that's not going to be a bad thing. And as the point that was just made, if it means avoiding an even more costly, intensive type of encounter, urgent care, ER, then it washes out. If not, it's a good thing. A lot of employers do have, some level of cost share. Could be due to the high deductible plans and a fair market value, or just a nominal copay, and that might serve as a little speed bump or impediment that the visit is marginally necessary, maybe I'll think twice. But the issue of induced demand is going to be less than, say, at a traditional bricks and mortar center, where someone is leaving the work environment for as little as a half hour or an hour.
Thank you. Rita, how do you measure the impact of virtual care?
I think it depends on the what you're interested in measuring. First, we have to measure to learn. I think, one, patient satisfaction is key, whether it's Press Ganey, MPS, surveying the population to better understand how they're adopting the tool and what they're using it for, when and where, is very insightful and can give an organization a lot of information about how they want to promote the service. The other, you want to know outcomes as well. So again, measuring the data, having that capability up front to know what you're looking at. I think operationally, it may be for a virtual urgent care model, you want to drive utilization, you want to see what that looks like, but maybe for primary care, it looks different. And then also looking at the diagnostic data that is coming in and adjusting your platform based upon how your population is using it. Having those quality metrics in place. I could give an example of a virtual care model where we were measuring antibiotic stewardship. And this is so important in the virtual world because a lot of people, oh, I'm going to do a virtual visit, I'm going to get my antibiotic, my Z-Pak. So there was a lot of education up front with the medical team as to antibiotic stewardship, and then we were able to back it with the data. But I'll tell you, what we found is that steroid prescribing went sky high because our providers felt like they needed to give every upper respiratory infection a steroid. So then that drove another quality improvement. So it's about the measurement.
Now, Lori, how do you, what do you either ask to measure through performance guarantees, or how do you determine the quality of the provider's service?
So with our virtual urgent, it's a lot about utilization. We want to ensure that people are utilizing the service, utilizing it appropriately, that we, of course, are being good stewards of antibiotic and generics. We don't prescribe any controlled substances. So it depends on really the program. With urgent care, we generally are giving a performance guarantee of 25% ROI or 25% utilization. We're seeing average 45% utilization across the board. And we're looking at not only utilization, but diverted inappropriate claims. So diversion of ER, urgent care, and we're measuring that and sharing that with our clients.
Thank you. So let's just go with our last formal question before I ask the questions to the audience. Karen, what are the success factors to making virtual care and in-person care work?
It's educating employees, number one. Well, before that, it's finding the right providers. We are on our second on-site clinic, and it was culture fit, having the right provider in the on-site clinic. And then with the telehealth, again, it was making sure that it was a good service, it was a quick service. It is, and so employees promote that to each other, and employee word of mouth is the best way to go. We can put out 1 million communications, but if employees are loving it, they're going to tell each other. And so it's just making sure that you have the right fit for your company. We talk to a lot of telehealth providers, a lot of on-site clinic providers, and it's just making sure there is a culture fit, and then that service level is there.
Lori, what are the success factors for making this work for employees?
Well, I think I left out earlier, certainly the member experience, and those surveys and net promoter scores are extremely important. We believe the speed to access, that's something that we're always measuring. Being able on demand to get a physician on the phone with you in less than 7 minutes, and as Karen mentioned, sometimes 2 minutes, and then being able to resolve that problem for you. So that's really what we're focused on, is making sure that we're taking good care of the members, listening to their issues, and then providing quick resolution, and then follow up with that patient when necessary.
Rita, success factors for integrating virtual and in-person care?
I think number one is the right fit, it's the culture fit, fits with your organizational values and mission. Number two is making sure that that fit has the right technology to provide for what you're looking for and is a good partner. And then number three is just the sharing of data is key to really drive population change with I'll bring a click and mortar strategy.
And Bruce, your success factors for making integration work?
Yeah, so I have the luxury of a few minutes to jot down thoughts, and I think they've been covered, but to maybe share them in my way of thinking. It's not that dissimilar from what we looked at with the world of on-site clinics a decade or more ago. I mean, communications and awareness. You need to make sure the eligible population are well aware of what's being offered and emphasize why it's of significant value to employees and their eligible families. You know, the underutilized program, virtual or in person, we used to define as the failed program. Britta and others talk about cultural alignment, whether that means, you know, having both services and clinicians who can connect with the population, and that can take a number of dimensions. And then I think, you know, provider retention, stability, and attitude are critical. You know, folks who really are passionate about practicing in this type of setting and have, you know, a true desire to connect with their patients and build a level of trust, understanding, and begin to succeed in changing behavior, not over an encounter or two, but over a long-standing patient-provider relationship.
Thank you. All right, questions from the audience? Anything we haven't covered? Yeah, Tim?
My question is mostly to Lori, because your service is to a wider population, so rather than just a company. A wise physician once told me, taking a history is 90% of the diagnosis. I think it's true. If you take a good history, you can diagnose people 90% of the time. And of course, that takes time.
Taking history takes time. But when it comes to acute episodic things, the medical decision-making is much simpler. It's almost protocol. I mean, it's like name that song. How many words do you need here? 4 words, I can diagnose sinusitis. The problem you talked about a little bit was the antibiotic use and meeting expectations. So the patient expectation is, I have this 4 symptoms, and last time I got this, I got Z-Pack. And your next move as a doctor is, okay, where's your pharmacy? But, so it's 2 minutes of listening and 10 minutes of explaining why you don't want to give an antibiotic. So how do you manage that? And I heard you say you had some nurses or people to follow up, so I assume there's something there to help manage expectations when people think it's a simple call and write you a prescription.
Well, so our physicians have clinical protocols that they're following. We have a record of the patient's visits previously. And I'll just give you a personal experience. My husband struggles with sinus issues. So one call, his symptoms clearly called for an antibiotic and a bleed steroid. A couple of months later, he had similar but not the same issues. And on demand, speaking with a physician, there was not an antibiotic prescription. It was a different type of medication. Some of it was over the counter, and to try that for several days, and then to call back or see his UT Southwest primary care physician, which he was. So he did actually call back a couple of days later. He wasn't feeling well, he was doing a lot of traveling, and at that time, an antibiotic was warranted and prescribed. So we're very cautious and very in touch with antibiotic stewardship, prescribing generics, and we know that commercials do motivate
consumers to call and ask for certain medications. And as you said, it's the time and the conversation, understanding what that patient is really dealing with, their symptoms or history, but then explaining to them what is the right clinical practice, and pretty stringent on that.
Yeah, go ahead, Dennis.
The organization has a medical model. Are you in a position in doing this with checking out preventive services or chronic condition management and saying, oh, by the way, your doctor wanted you to have an A1C or thyroid or whatever, or mammogram, and try to integrate with what's going on in the clinic?
So were you referring that to all of us, or? Okay, so I'll just start to say that with our virtual primary care model, absolutely, we're looking to ensure that patients are having their preventive screening. We're tracking and following up to ensure that that's been completed, nudging them to get that scheduled, so on and so forth. So it's a big focus for our primary care component, is that prevention, but also identifying issues, chronic conditions, and dealing with those early, educating the patient, sending them the right devices that they need, if it's a blood pressure, whatever, kit. So it's, I think, very similar to a brick and mortar, but it is done virtually. Of course, there are times when we need to refer to a face-to-face primary care physician or to a specialist, and of course, we're referring for lab and X-ray and all of those things that can't be done virtually.
And now too, a lot of the national labs, for instance, do mail out kits for a lot of the different screenings, testing, biometrics, but for gap closures, which is very much top of mind, I think it really depends on the location of who you're serving in that community and what resources they have to close that gap. But yeah, very much a part of what a virtual service can do.
Other questions? Final one. We have I have vendors call me every week. There's not only dermatology, there's telechiropractic, teleacupuncture, teledisease management, Is it just technology that's going to limit our ability to offer these services, or do we have to be careful in what we're trying to do virtually? Anybody?
Well, certainly, Larry, to your point, technology has opened the lens whereby, with peripherals, whether it's a dermoscope, an electronic stethoscope, otoscope, clinicians have those diagnostic tools. So technology may, and it likely was a gating factor in the past, and nonetheless, there will be some things that will be either difficult to engineer or to get adoption. So I'm not aware of the electronic colonoscope yet. Though I suspect that it may not be too far off, but good luck trying to drive significant use. It's going to be a combination, but the emergence and explosion of technology will further widen the eligible types of conditions and clinical situations that can be managed. There's also patient adoption. It could be older folks like some of us that just may not be as comfortable. I think we're going to see the physicians who have been resistant, they're going to be in the sunset of their careers and wind down. But those who are earlier on or in training, they're going to embrace this, and it'll be part of how they practice, how they manage patients. So a combination.
Last question for Brita. Is virtual care a buy-up, or is it going to be part of the core services offered by states?
Tough question. I think it all depends on the contract and the agreement. It really depends on what type of service the client is purchasing. Is it a wraparound service? Is it just using the on-site providers, doing virtual care certain time during the week? So I think I guess I'd ask the others how you see that.
We've been offered it as a buy-up through our on-site clinic and declined for a couple of different reasons. They're new at it. And I believe in looking at vendors who are good at what they're doing and can focus on one good thing sometimes. That's the best use of our dollars a lot of times. So it was a buy-up in our case, and personally I found the telehealth much more cost-effective and to be meeting the needs, so it worked for us.
Larry, what I heard yesterday, one of the breakouts by a leading consultant in the field is that most procurements or RFPs, if not almost all, are including virtual. So I think for new models where employers are seeking directed primary care services, we're seeing virtual incorporated, but for those who may have legacy bricks and mortar, it often will be a buy-up, or there'll be they'll contract newly for a combination. So it'll be a little each. I think Britta was correct. It depends on the situation and contracting.
Thank you. Well, let's thank our panel for a wonderful presentation. And let me ask the final